Hello, I'm Joyce O'Shaughnessy. I'm the Celebrating Women's Chair in Breast Cancer Research at Baylor University Medical Center, Texas Oncology, and U.S. Oncology in Dallas, Texas. The long-awaited RxPonder, or responder, as I say, data were presented by Kevin Kalinsky at San Antonio 2020. Very important practice-changing data, I think. And in the RxPonder, patients premenopausal and postmenopausal with early stage ER positive, HER2 negative breast cancer who had 1 to 3 positive nodes, their breast cancers underwent the 21 gene recurrence score evaluation. And if the recurrence score was 25 or less, in addition to receiving standard endocrine therapy, the patients were randomized to receive chemotherapy, adjuvant chemotherapy, or not. And the hypothesis was that for patients whose recurrence scores were 25 and less, that those breast cancers would be very endocrine therapy sensitive, and the patients would not benefit additionally from what would be considered a standard of care with 1 to 3 nodes positive chemotherapy. And the primary endpoint was invasive disease-free survival. At the time of the oral presentation at San Antonio, median follow-up was 5 years, and 5,000 women had been randomized to chemotherapy versus not, in addition to standard endocrine therapy. And the primary endpoint of invasive disease-free survival was statistically significantly in favor of the addition of chemotherapy to the endocrine therapy, with an improvement in 5-year invasive disease-free survival of 2.9%. And that was statistically significant. Interestingly, patients who had the highest recurrence scores, they did have the highest risk of having a recurrence, but the benefit that was accrued from chemotherapy did not increase proportionally as the recurrence score rose. So there was not a relative increase in chemotherapy benefit as the recurrence score got higher. So the recurrence score in this node positive population was prognostic, but it wasn't predictive of chemotherapy benefit. But the real surprise came in looking at postmenopausal and premenopausal patients. In the postmenopausal group, regardless of whether the recurrence score was 0 to 13 or 14 to 25, and regardless of whether the women had 1 positive node or 2 to 3 positive nodes, there was no improvement at all in invasive disease-free survival with chemotherapy. Conversely, in the premenopausal patients, there was a statistically significant improvement in invasive disease-free survival in the entire premenopausal group of 5% improvement. And that was true whether they had 0 to 13 for a recurrence score or 14 to 25, and as well whether they had 1 or 2 to 3 positive lymph nodes. In addition, there was no improvement in survival in the postmenopausal patients, but in the premenopausal patients, although the absolute improvement in survival was only 1.3%, the hazard ratio was 0.47, and that was actually statistically significant improvement in survival in the premenopausal patients. And so what are the clinical implications of these very important RxPonder data? Well, it tells us that for postmenopausal patients with 1 to 3 positive nodes and a recurrence score 25 or less, that we really cannot see a benefit from chemotherapy in that patient population. And so it's very reasonable for the most patients to not recommend chemotherapy to those patients. Conversely, in every premenopausal group, even they had 1 positive node or even recurrence score 0 to 13, they all had about a 5% absolute improvement in invasive disease-free survival, suggesting that all patients who are premenopausal should get adjuvant chemotherapy. However, there's just one important caveat to know about, and that is that in the premenopausal population, in the endocrine therapy alone arm, only 16% of those patients received an LHRH agonist, and it was 3% in the chemotherapy arm, because the RxPonder trial started before the data from the soft and text trials were available. And so patients ended up really not getting today's defined optimal endocrine therapy. And so the question is, to what extent was adjuvant chemotherapy really functioning to suppress ovarian function? And is there a group of patients that could really benefit from an LHRH agonist plus an aromatase inhibitor, optimized endocrine therapy, and that in fact would not benefit at all from chemotherapy? Chemotherapy would only have an ovarian function suppression effect. We don't know that from the RxPonder data. And so in my practice, I will look not only at the recurrence score for the patient, I'll look at the strength of the estrogen and the progesterone receptor, the grade of the cancer, the Ki-67, and overall tumor size, et cetera. And if a patient really has very strongly ERPR positive disease, grade 1 or grade 2, and a low Ki-67 under 15 or 20%, and she has one node positive, for example, that's a woman I probably would be comfortable talking about an alternative to chemotherapy, which would be an LHRH agonist or a bilateral salpingo oophorectomy plus an aromatase inhibitor. So we're kind of left with the RxPonder like we have seen with the MINDACT trial, which also enrolled women with 0 to 3 positive lymph nodes, and the benefit from chemotherapy in the clinically high risk, genomically low risk group. There was a benefit from chemotherapy in the premenopausal patients, but not in the postmenopausal patients. And again, in the MINDACT trial, a minority of the premenopausal patients received an LHRH agonist. So we're seeing across trials now a benefit from chemotherapy only in the premenopausal population, which really does suggest that the chemotherapy is having mainly an ovarian function suppression effect. So I think it's very reasonable not to give every premenopausal patient who has 1 to 3 positive lymph nodes adjuvant chemotherapy, but to look as well at the biology of her breast cancer and sitting down and really talking to the patient about these various options.